All right, you guys, welcome back to another video lesson. My name is Eddie Watson, and this is ICU Advantage, where I'm giving you the confidence to succeed in the ICU by breaking down these complex critical care subjects and making them easy to understand for you. And if you'd be interested in getting these critical care lessons on a weekly basis, then I invite you to subscribe to the channel down below. When you do, though, make sure you hit that bell icon and select all notifications. That way you're never going to miss out when I release a new lesson. Now, in this lesson here today, we're going to be talking about the different modes that we have for our temporary pacers, as well as covering some of the basic settings and sort of basic operational information. In order to be able to effectively manage a patient with a temporary pacemaker, at a minimum, you need to understand the differences between these modes, as well as the basics for the operation of this pulse generation. So make sure and keep watching, because I've got a lot of great information for you guys. All right, so here we are continuing our discussion talking about temporary pacemakers. So in this discussion, the first thing that I actually want to talk to you guys about are the different modes that we have for our pacing. Now, the way that a pacemaker operates is based off of three primary things: where it's pacing, where it is that it's sensing the intrinsic rhythm from, and then what to do if a sensed beat is detected. Now, there's a nomenclature that we use in order to be able to tell us all three of these things and then how this pacemaker is actually operating. There's basically a three-letter code that is going to tell you what type of operation that pacemaker is currently operating in. In order to help you remember what each one of those letters stand for, it helps if you can remember the acronym PSR. And this is going to stand for paced, sensed, and response. All right, so let's actually talk about these so they make a little bit more sense. Now, paced, I think, is pretty self-explanatory. This is going to be, where is this pacemaker pacing? And so then for this first letter, we have three options to choose from: A, V, and D. Now, A stands for the atrium, V stands for the ventricle, and D stands for dual or both chambers. And so what this is telling you is if the first letter in the three-letter mode setting for our pacemaker is an A, this means that we're sending pacing to the atrium. If it's a V, it means that we're sending pacing to the ventricle. And if it's D, then it means that we're sending pulses to both the atrium and the ventricle. All right, so that's our paced. Now, the second letter is going to be our sensed. And here we're actually going to have four letters: A, V, D, and O. Now here again, A is atrium and V is ventricle, and then D stands for dual, and O means none. And so what we're talking about when we're talking about sensing is the pacemaker's ability to pick up on the intrinsic heart rhythm. And so in the cases here, are we sensing that rhythm from the atrium, the ventricle? Are we looking at both of the chambers here? Or are we not doing any kind of sensing? And the sensing plays an important role in the third letter of our mode setting. That's going to be our response, which is this is our response to a sensed event. Now for our response, we also have four different letters that we can use here. We have T, I, D, and O. Now T stands for triggered. Now in order for me to explain about triggered, it actually helps if I mention what the I stands for, and the I is inhibit. This is also something that we refer to as demand mode. And the reason for this is, the reason we call it inhibit is because when it senses an intrinsic heartbeat, that it's going to inhibit the pacer from firing. So if it senses that the patient has a heart rhythm, it's not going to fire the pacer, and it's only going to fire the pacer whenever it's needed or demanded. Now, going back to triggered means that we're going to trigger an action whenever a intrinsic heartbeat is recognized without any inhibition. Now, this might not make a whole lot of sense. I'll kind of try to loop back to this and sort of fill in the gaps, but the important thing to know here is that having a pacer in the mode of a T response actually has no clinical application when it's only triggered alone. To try to explain that a little bit better, let's actually move on and talk about the D, which stands for dual. And this means when it senses an event that it can both inhibit and trigger an action. And just a really quick example to make this make sense for you guys. If it senses a beat in the ventricle, it's going to inhibit the pacer from firing because the heart is already contracting. Whereas if we maybe sense a beat in the atria, that this could trigger the pacemaker to send a pulse to the ventricle. So depending on what mode we're in and where we're sensing this intrinsic heart rate, that this is going to determine what we're going to do with it. So going back to that T triggered, while it makes sense sometimes to have a triggered response, to trigger without any sort of inhibition really doesn't have any clinical application. And then finally we have O, which again stands for none. And this means we're basically not going to have any kind of response to any sort of sensed event. And so in fact, we're only going to see an O for the third letter when we also have it for the second letter, basically meaning we're not doing anything with sensed beats. We just essentially have the pacemaker firing. And so this is why this is also referred to as asynchronous. Now, on that topic, I actually do want to talk about the difference between asynchronous versus synchronous pacing. And so we can either have the pacemaker operate in synchrony with the patient's intrinsic rhythm, or the pacemaker can operate independently. Operating independently means we're not sensing the underlying heartbeats, and this is what we refer to as the asynchronous. And if we are working in synchrony with that intrinsic rhythm, this is where we were talking about having the demand mode. We're either going to send pulse generation to the heart and not care about what the heart is doing underlying, or we're going to sort of listen to or sense those intrinsic heartbeats, and then based on what sense, determine whether or not we need to give a pulse generation. Now again, it's important that you understand that because operating in asynchronous mode means that we're going to continue to fire without any regard to what the heart is doing on its own. Now, we know that the heart's only going to contract when the ventricle is not in its refractory period. But if it's outside of that refractory period and we're just sending pulse generations whenever we want, we really run the risk of triggering a beat during the repolarization, that R on T event, when we're operating in this mode. And this could trigger ventricular fibrillation, which obviously is not going to be good for our patients. So in almost all cases, with the exception of some pretty, within the ICU, some pretty infrequent situations to encounter, we're almost never going to use asynchronous mode. And this is only something that we want to be using on patients who are fully dependent on their pacer. So as I go through, I will talk about some of these specific asynchronous modes, but again, just realize that the chance that you're going to be using one of these is probably pretty slim. All right, so with that stuff out of the way here, the next important thing for us to talk about is going to be the difference between our single chamber and our dual chamber pacemakers. And so just as we had in the intro, here is a picture of a couple examples. These happen to be the Medtronic, the newest version of the Medtronic temporary pacers. We have on the left is actually our dual chamber pacemaker, and then on the right is the simpler single chamber. And so let's actually start off talking about the more simple one, the single chamber. Now this one, as the name suggests, can only sense and pace a single chamber of the heart, either the atrium or the ventricle. Now, like I said, this is simpler to operate as there's really less modes available to us and less settings to have to change. As you can see looking here at this example, we just have the 3 knobs or the dials to be able to change, then just a couple buttons. So not a whole lot of settings to deal with here. Now, like I said, there's only a couple modes that we have available on here. And really these modes are going to be dependent on where it is that your pacer leads are going to. If you have leads going to the atrium, you're going to only have 2 different modes that are related to the atrium to choose from. And then if your leads are then going to the ventricle, then you only have 2 different ventricular modes to choose from. So we'll actually start off talking about our ventricular modes, and there's 2 different modes. We have VOO and VVI. So let's actually work through these first 2 a little bit slower. If you remember that acronym PRS, Paced Sensed Response. So in this first one for VOO, the first letter is a V, which means we're going to be pacing to the ventricle. The next 2 letters, though, both for sensed and response, are O, And if you remember, that means none. So this means we're not going to be doing any sensing, and there's not going to be any response to something that we're not even sensing. And so this means that this is actually our asynchronous mode, and again, isn't going to be one that you're probably going to use a whole lot. Now for this other mode, VVI, so again, we know we're pacing in the ventricle. Now for the next letter, the sense, that this is a V, so this means we're going to be sensing from a ventricle. And if you think about it, it kind of makes sense. We only have one pacer wire, so we're going to have to be sensing in the same place that we're pacing. Now for the third letter, this is the response to a sensed event, and here this is going to be an I, and this means inhibit. And so this tells us that when we sense a ventricular beat, we're going to inhibit the pacemaker from firing a beat. Makes sense. If the heart's already contracting, we don't need to send a paced beat to it. We only need to do that when it's not. And so again, this is going to be a demand mode. And actually, VVI is one of the two most common modes of pacing that you're potentially going to see. Now, both of these two modes, when they're operational, is something that we refer to as being V-paced. And so let's actually take a look at a rhythm of what a patient who's being V-paced is going to look like. So as you can see here, we have our pacing spike, which is going to be from our pacemaker firing, and you can see each of those right along here. Now following the pacer spike, we have our ventricular beat, which you can really kind of tell that because it's a little bit wider, almost like you'd see a PVC. Again, because we're not using the fast paths of those bundle branches and Purkinje fibers to send that signal around. Now in this example here, every single beat of the patient's heartbeat is coming from a pacer-generated pulse, which basically tells us that either the patient's heart rate is lower than what we have this pacemaker set at, or they just don't have any intrinsic heart rhythm to begin with. But like I said in VVI, we're actually working in demand mode, and so this means we're not always going to be giving a pulse generation. It's going to be based on what the patient's underlying rhythm is. So here's an example of that. And so in this example here, you can see our first couple beats are actually normal beats. We don't see any pacer spikes. But then after that second one, a long enough period of time goes by that the pacemaker needs to then kick in order to maintain the rate that it's set at. So we have a few beats that go along that are paced, and then the patient's intrinsic heart rate picks back up, and we go back into the normal rhythm that you see. So here we're sensing for those intrinsic beats. So when the pacemaker sees them, it's going to inhibit that pulse generation until it gets to the point to where that it no longer senses it, and then it's going to kick in and send those pulses or that stimulation to the heart muscle. But then after each beat, it's going to continue sensing, and if it senses it again, then it's going to go ahead and inhibit once again like we see at the end. Now VVI, again, remember that this is a single chamber mode, so just to recap that we're going to be sensing and pacing in the ventricle. Now, important to know with this is that it will not necessarily be in synchrony with the atrium contracting if the patient is in a sinus rhythm. And so since we're only pacing the ventricles, we're often going to see a decreased cardiac output because we're going to be losing that atrial kick. And so this may require running the rate a little bit higher than we normally would think to. So those are our two ventricular modes. Now let's talk about our two atrial modes, and these are very similar, AOO and AAI. And again, these are what we're going to be referring to as being A-paced. And so again, let's bring up an example of what just straight A-pacing looks like. And so here again, we can see our pacer spikes right along here. But this time you can see that the spike is actually preceding a P wave. And then following that P wave, we actually have normal looking QRS complexes. So now hopefully the naming convention is starting to make a little bit more sense here. So again, we have AOO. That means we're not sensing or responding to any kind of sense event, which means that, again, this would be our asynchronous mode. And then AAI means that we're now sensing in the atrium along with pacing in the atrium. Again, duh, makes sense. We only have that one lead. And then our response to that sensed event is to inhibit, which means this is our demand mode. And so let's actually take a quick look at that one here. So again, at the beginning, we can see our normal patient rhythm that's going there. After the second beat, we have a long enough delay that this is going to trigger the pacemaker to fire, but now we have an atrial paced beat. And so we're going to see that normal morphology P wave and then followed by a normal QRS complex. So we have a couple of those beats, but then we see that the patient's intrinsic rhythm picked back up in time, so our pacemaker sensed that and didn't send an atrial pacer spike, but then again it had to do it again here at the end. And so then just for clarity's sake, we know that this is going to be sensing and pacing in the atrium. We're going to have that normal P wave and QRS complex morphology. But an important distinction here is that and hopefully that makes sense to you guys why that is, because here we're only sending impulses to the atrium. We're not sending anything to the ventricle. This is just a single chamber pacemaker. So if there is no intrinsic heartbeat and we send that pulse to the atrium, it will cause contraction in the atrium. But if there's no conduction through the AV node, we're not going to pass that signal on to the ventricle and we're not going to get any sort of heartbeat. So really important to know, we can't use that here. So those are our single chamber pacemakers. As you can see, we just have really kind of two options, VVI or AAI, because again, we're probably not going to be using one of the asynchronous modes. Pretty simple. Are we pacing in the ventricle or pacing in the atria? And so now let's actually move on and talk about our dual chamber pacemakers. Now here again, you can see another example of this here, and you hopefully can see how much more complex this potentially is going to be than just the single chamber pacemaker. We've got a few more dials and knobs, and there's actually a whole nother screen which is going to display additional settings for us on here. And the reason for this is because that this particular pacemaker is going to offer the greatest flexibility in our pacing options for our patients. And part of the reason for this is we can, with a dual chamber pacemaker, operate in single chamber modes just as like we just talked about. But using this particular pacemaker, if we have atrial and ventricular wires present, then this is going to open up even more modes for us to work with. And so having both of those pacing leads is going to open up 3 additional modes for us. We have DOO, DDI, and DDD. And all of these modes would give us something that we refer to as AV paced. And so again, let's take another quick look at what that would look like here. And just as the name suggests, and the first letter that we see in the mode nomenclature is a D, which we know means dual or both chambers. So all 3 of these modes start with that D, which means we're going to be pacing both the atria and the ventricle. And so here we can actually see pacer spikes, and you have a set of pacer spikes for each heartbeat. Now in this example here, the first pacer spike is our atrial pacer spike, which is then preceding the P wave, causing the atrium to contract. And then the second pacer spike is our ventricular pulse, which is then preceding a wider QRS complex and is triggering that ventricular contraction. And so again, hopefully looking at the names of these modes that this is starting to kind of sink in for you guys. So again, DOO means we're doing dual chamber pacing, but we're not doing any sensing or any obvious response to a sensed event. So this is going to be our asynchronous mode. And I'll actually come back and explain what DDI is, because it's going to help to understand DDD to better understand DDI, which is a little bit different than what we've just been dealing with, because in the single chamber pacemaker, the most common mode that we used was the inhibit mode, either VVI, which is the most common, or AAI. But here in our dual chamber pacing, DDD is going to be the other one of those 2 most common modes that we use. So here again, we know that this mode senses and paces in both chambers. Now, the important distinction here is that final letter. So we know we're doing dual chamber pacing, dual chamber sensing, and dual mode of a response to that sensed event, which if you remember means we're either going to inhibit or trigger. And so what it does when it senses a beat is really going to depend on which chamber it is that it senses. So if neither the atrium or the ventricle is sensed, it's going to deliver a stimulus to the atrium, followed by a delay, and then to the ventricle. Now, if the atrium is sensed, that this is going to inhibit our atrial stimulus from being sent. And so the pacemaker is going to continue to be sensing now in the ventricle, but if after a specified period of time there is no ventricular beat, then the sensed atrial beat is actually going to trigger a stimulus to the ventricle. So hopefully this makes sense. If we sense that the atria has contracted, we're not going to send another pacer spike to the atrium, but we're going to wait and give it time and see if that signal actually propagates to the ventricle. If enough time has passed and it hasn't, then we need to stimulate that ventricle to contract. And then finally, if the ventricle is sensed, regardless if there was an atrial sensing or not, then both the atrial and ventricular leads are going to be inhibited from sending a stimulus. And this is really the meat and potatoes of that last D, that response to a sensed event, because that same sensing can either inhibit the atrial pacing or it can be used to trigger the ventricular pacing. And so it's really doing both modes. So again, if it senses in the ventricle, it's just going to be inhibiting here. There's no triggering happening. And so with that explanation out of the way for DDD, it helps to make the understanding of DDI a little bit easier, because this one's similar to DDD, except the only atrial beats that are going to trigger ventricular stimulation are going to be ones that we provide, so the paced atrial beats. And the whole purpose of this is it's going to prevent high ventricular rates in patients with proximal AFib. So in the case of AFib, where that atrium is just contracting at a very high rate, if every single one of those was passed along to the ventricle, we would have a very high ventricular rate. So we wouldn't want that happening. So we're actually going to inhibit that from taking place. And then the only time that we're going to have a atrial beat that we sense that's then going to trigger a ventricular beat is if it's one that we provided the stimulus for, so we can actually control that proper rate. So now, interestingly, the pacing example that I showed you here, this was just 100% AV paced. I do want to actually show you another example that's going to show us several different types of paced beats that we can see for a patient in pacer mode of DDD. All right, so number one, this is going to be just our normal intrinsic patient heartbeat. Pretty self-explanatory. Now, number two here, this is going to be one where enough time elapsed and we did not sense an atrial beat, so we sent an atrial pacer spike, but then again we waited and enough time went along that we didn't see a ventricular beat, so then we also triggered into a ventricular beat. Now in example number three here, this example again, enough time went along that we didn't see an atrial contraction, so we had to send a pulse to stimulate atrial contraction. But this time, that atrial contraction and that depolarization made it through the AV node and onto the ventricle in enough time, so then we see that we have a normal QRS complex and no second pacer spike. And then finally, in our fourth example here, in this example, the patient ended up having their own intrinsic atrial contraction, but as enough time went on, we didn't see that ventricular response, so the pacemaker then used that sensing of the atrial contraction to trigger the pulse generation, causing contraction in the ventricle. So kind of crazy that we can see 4 different types of beats in patients who are in a dual chamber pacemaker set in DDD. All right, so that's the big difference between the single chamber and our dual chamber pacemakers and the different modes that we have available to us in there. And so now lastly, let's actually talk about some of the basic settings that we have. Now, this isn't going to cover all of the settings that we see in the pacemaker. I'm actually going to have a separate lesson that's going to go more in detail into some of the more advanced, if you will, settings that we can change on the pacemaker. But these are going to be the most basic ones that you really have to understand if you want to be competent in caring for patients with these pacemakers. And the first thing that we're going to talk about is going to be our rate. And this one's really the simplest of these settings that we have. Essentially, it is the rate at which you want to pace your patient's heart rate. And so if our patient's intrinsic heart rate drops below this set rate here, then the pacemaker is going to stimulate a contraction. Now, interesting though is that the pacemaker actually works off of timing. So instead of measuring the beats per minute like we normally do when we look at things, it actually measures how much time has taken place since the last event. And this time is actually measured in milliseconds. And a simple example is as if we have a patient who has a heart rate of 60 beats per minute. This means that they have 1 beat every 1,000 milliseconds, or more simply, they have 1 beat every second. And so if we then had our pacemaker set with a rate of 60, then if 1,000 milliseconds or 1 second has gone by and it hasn't had another sensed event, then this is going to trigger the pacemaker to fire a pacing spike. So pretty straightforward, other than the fact that it's just looking at the time that takes place between each beat. So the next important setting that we're going to have on our pacemaker is going to be our mode. Now, in our single chamber pacemaker, you're not going to have a direct way of changing the mode. Obviously, if your pacer lead is in the atrium, you're going to have an atrial paced and sensed beat. And if your lead is in the ventricle, then you're going to have a ventricular sensed and paced beat. But you do have ability to change the synchrony. So again, think your AOO versus AAI or VOO versus VVI. And basically the way that you activate this asynchrony is to turn the sensitivity all the way up until you reach that asynchronous mode. Now, on the dual chamber pacer, you've got a long list of modes that you can choose from. And again, they can operate in single chamber modes as well as the dual chamber mode. So you've got AOO, AAI, VOO, VVI, DDO, DDI, and DDD. Now on the dual chamber pacers, you can either just set this directly or there are some things you can do to actually trigger it to go into one of these modes. So again, if you're in VVI, let's say, so you're ventricular sensing and ventricular pacing, but you turn the sensitivity all the way up just like you did on the single chamber pacemaker, that's going to put you into asynchronous mode, which is by doing that flipping you into VOO now. So there are some ways to do that with some of the settings on the dual chamber pacers, which I'll probably talk about in that other lesson where we go a little bit more in depth into some of the more advanced settings. But I do want to move on next from here and actually talk about the next setting, which is going to be our output. All right, now the output, this is going to be a measure of the stimulus pulse generated in milliamps. Now the point of our output is to stimulate capture, and capture is going to be defined as the stimulus leading to a contraction of the heart. Now, if our milliamps are not high enough to stimulate this contraction, then no capture is going to be present. Now, to understand this concept, there's something that we have that we call the stimulation threshold. And this is essentially the minimum output in milliamps that's needed to consistently lead to capture. And it's important to know that this isn't always just a fixed value. So age of the leads, drug therapy that the patient's on, their acid-base status, that this can all impact this stimulation threshold. And so because of some of these fluctuations, if possible, we want to try and maintain what we call a 2-to-1 safety margin above our threshold. So this way we know that if some of these values change and this threshold becomes higher, that hopefully we have our output set high enough that even with those changes, we'll still continue to get capture. And so fortunately, there are some pretty simple steps in order to figure out what this stimulation threshold is. So the first is we want to set the rate at least 10 above what our patient's intrinsic rate is. Then we want to decrease the output, so this is our milliamps, until we have the loss of capture. Now when you do this, you're going to be seeing the pacing and the sensing lights flashing intermittently. Now from here, we want to increase the output slowly until we have consistent capture. And so this here is going to be our stimulation threshold. And so finally, once we know this threshold, we want to set our output 2 to 3 times this threshold. All right, and then finally, the last setting that I'm going to talk about is going to be our sensitivity. And so when we talk about sensing, like we said, this is the pacemaker detecting the patient's intrinsic heart rhythm. Sensitivity then is the measure in millivolts of the required amount of electrical energy needed to detect that heartbeat. Now, this particular setting often confuses people. The higher the sensitivity, the less likely that the pacemaker is to see the patient's intrinsic rhythm. And so to help you kind of understand this a little bit better, let me put up a strip with a just basic sinus rhythm on here. And so we can really think about our sensitivity kind of like a fence. Now, in the case where our sensitivity is too high, the fence is too high, and as you can see, you can't actually see any of the intrinsic heart rate. But if we're lowering that sensitivity and we lower it just enough, then we can get it to the point where we can just see the patient's intrinsic heart rhythm. Continuing along, if you lower it too much, then it's going to start to see every single thing in there and consider all of that the patient's intrinsic heart rhythm. So again, like I said, the higher the sensitivity, the less likely the chance that we are going to have our pacemaker seeing the patient's rhythm. Now, once again, similar to our output for our sensitivity, we actually have something that we call our sensing threshold. And this is going to be the least sensitive millivolt setting in which the temporary pacemaker can detect a heartbeat. Now again, the age of the leads, the drug therapy, patient's acid base status, that this can all affect this threshold. And again, if possible, we want to try and maintain that 2-to-1 safety margin below this threshold. So once again, we do have some steps in order to help us determine what this sensing threshold is. Now, important to know though that you only want to perform this if your patient has a sufficient intrinsic heart rhythm underlying. So first we want to set our rate 10 below the patient's intrinsic rate. Next we want to turn the output all the way down to 0.1 milliamps. Then we want to start decreasing the sensitivity until the sense indicator light stops flashing. Now when the sensing indicator light stops flashing, we're going to have the pace indicator light, which is going to be flashing. But at this point, we're not going to have capture likely because we have the output set to just 0.1 milliamps. Now here we want to increase our sensitivity until the sense indicator starts flashing. This is going to be our sensing threshold. Then in order to maintain that safety margin, we want to set our sensitivity to half or less of what this threshold is. And then finally, most importantly, restore the rate and the output to the previous values. And that is our sensitivity. Those are the basic settings that you really have to understand when you're operating a pacemaker for your patient. And then overall, that's this lesson covering the different modes and settings at the basic level that you really need to understand in order to be competent in being able to take care of a patient that you find yourself with that has a temporary pacemaker. So I really hope that you guys enjoyed this lesson. If you did, please leave this lesson a like. Go down in the comments, leave me a comment, let me know what you thought, and make sure and share this lesson with other people that you think might also enjoy it. As well as if you haven't already, make sure and subscribe to the channel down below there as well. A special shout out to our YouTube members and Patreon members out there. The support that you guys offer for this channel really goes a long way in allowing me to continue to do bigger and better things for this channel moving forward into the future. So a big thank you to you guys. Now, for the rest of you guys, if you'd be interested in showing additional support for this channel, you can either join the YouTube channel membership down below or head on over to the Patreon page and check out some of the extra perks that you get for doing just that. As well as you can always support this channel by following the links that I have down in the description or checking out some of the really awesome t-shirt designs that I have linked to just below this lesson here. Make sure and stay tuned for the next lesson in this series, but in the meantime, make sure and check out a couple really awesome lessons that I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.